All right, guys. Floating ventilator guys back. Appreciate everyone's feedback on the videos thus far and hoping to go through the normal waveforms in a timely fashion. And we'll start today with pressure control. And I have sort of a deal pressure control tracing, which is from a PowerPoint presentation shared with me by my former attending and mentor and the person that really taught me mechanical ventilation, the ventilator course, Dr. Emil Owais. So appreciate his sharing this with me. This is all of his drawings and animations. So please respect and certainly teach and share, but realize that someone did put a lot of time into these really great drawings. So we're going to start with pressure control. And if you watch the Ohm's Law video and have sort of been following along, the way that we teach the ventilator is based around Ohm's Law and the equation of motion, which is P airway equals flow times resistance plus volume over compliance plus PEEP total. Obviously, we're drawing in green because we're Eagles fans and go Birds. So we start with P airway equals flow times resistance plus volume over compliance plus PEEP total. Now, where we need to start is on pressure control. What do we set as the operator, and what is the result of what the patient characteristics, and then what can be a result of the patient's interaction with the ventilator? So let's assume right now that the patient is passive or paralyzed. And like I talked about in one of the other videos, is when we start to get the different pressures like plateau pressure and peak airway pressure and auto PEEP, to get these numbers and these measurements and for them to be accurate, the patient needs to be passive or paralyzed. So let's assume the patient's passive or paralyzed here. So in pressure control, we set the airway pressure, we set the PEEP. Now, even though in this equation, PEEP total is what counts, meaning if the PEEP is 5, but the total PEEP is 15 because there's auto PEEP, that will influence things. And we're going to talk about that. But for right now, let's just say that PEEP total and set PEEP are synonymous. So we set the airway pressure and the PEEP total. The flow is partly based on patient characteristics and the patient's interaction with the ventilator. So let's leave that to the side. The resistance is a patient characteristic, at least in the airways. And then the resistance also, we sort of impact indirectly with the size of the ET tube. So if you have a 6.0 ET tube versus an 8 ET tube, your resistance is going to be impacted in a big way. And remember, it's impacted on a much larger scale, an exponential scale, in fact, because when you take into account the radius, resistance increases by a factor of 4. So that's something to be very cognizant of. But volume, so the compliance is a patient characteristic, and then the volume is not so much a patient characteristic, but it's sort of, we're going to get a volume that it will be dictated by all the other things, meaning if we set a higher peak airway pressure versus a lower peak airway pressure, if all things are equal, the volume should be higher. If we set a lower peak airway pressure, the volume could be lower. If the resistance goes up, if resistance goes down, if the compliance goes up, the compliance goes down. So the volume will depend on the patient characteristics, but also to what we set to some degree. So that's something to consider. But I think why it's generally taught and understood that pressure control is better for the patient because it's more comfortable is because in pressure control, the patient has more freedom to do what they want if they're interacting with the ventilator. So they have more control over how much volume they get. Now, you as the clinician or the provider, whoever's setting the ventilator, you need to ask yourself, is that okay? So if a patient has ARDS and you're really trying to adhere to the 6 ml per kg, well, if the patient's taking big, long, deep breaths because they have a lot of dead space or they have sepsis, whatever it is, and they have ARDS and you're trying to adhere to the 6 ml per kg, if you put that patient on pressure control and they can breathe freely, they might not breathe at 6 ml per kg. So even though it's quote unquote more comfortable, it might not be what's best for the patient at that time. So you need to take over control in some way. Now, whether that's more sedation or paralysis or switching modes or whatever you deem to be appropriate, while we want the patients to be sort of in control, we also understand that there's situations where they might need to have less control because of their pathology. So we start at pressure control. So we set the airway pressure. So let's just say we set the PEEP at, and I'll draw this in purple. So let's say we set the PEEP at 5 and we set the peak airway pressure, or let's say we set inspiratory pressure to 15, meaning the peak airway pressure will be 20. And remember, a fundamental difference between pressure control and volume control is that in pressure control, we set the inspiratory time. And that's not really represented in the equation, but we set the I time. That's the cycling mechanism, as a matter of fact, meaning if you were asked the question, when will the ventilator go from inspiration to expiration? The answer is after the time has cycled through. So let's say in this situation it would be 1 second. So we set that to 1 second. Now, this blue line here that is drawn in for you, that's the alveolar pressure. Because remember, if I sort of dropped a few lines, let's say I drop a red line, try to make this as straight as possible, and I dropped a yellow line, and that's a little bit off, but I think you get the gist, and then I drop a blue line, all these time points, the pressure is going to be different. So the alveolar pressure is going to be different. So in the very beginning of the breath, let's say the red line here, if you look, while the pressure has risen to 20 and the flow has exploded to some number, let's say, I don't know, let's say that's 60 liters per minute, there's still no volume delivered, right? So remember, this part of the equation that I talked about before is sort of X'd out because there's no volume, so it's 0. So pressure that's represented is really the PEEP, the flow of the resistance is going to equal the airway pressure. Now, as you start to inflate the lungs, so let's say we move to the yellow line, now you'll start to have some contribution to the pressure at least the alveolar pressure, that will be from the volume delivered. So your alveolar pressure will rise as you see the blue line rising. So let's say maybe we're sort of maybe halfway through or a quarter of the way or sort of getting there. So as alveolar pressure will rise, as we deliver flow, and remember flow, the area under of the flow time curve is the total volume, because if you do, so the x-axis is time and the y-axis is flow. If you multiply that by each other, you'd be left with just liters. So you deliver a total volume. So as you deliver total volume, your alveolar pressure will increase. Then at some point, remember the patient's not passive or paralyzed, so the volume that you're going to deliver is going to depend on the other functions of the equation, meaning the compliance, the resistance, the PEEP. So at some point, the alveolar pressure will equal the airway pressure. So we're going to say P airway equals P alv at end inspiration. So what you're going to see is, given Ohm's law, so flow will only occur if there's a delta pressure. If that delta pressure difference is no longer there, the flow times resistance component will go away. And what you'll be left with is P airway equals P alv. And P alv, as we talked about before, is really just this piece of the equation, which is V over C plus P total. So at this red line here, there's no flow, as you can see, right? Because the flow has come down to the baseline. And then the volume will be at its peak. That's how much it's completely in red on our area under the volume curve. Similarly, the area under the flow time curve, that represents the volume delivered. So using the equation of motion, you can hopefully see that these terms, if you break down inspiration, let's say it's three key parts. The beginning of inspiration, so where I have in red towards the right, the middle of inspiration, what I have in pink, and the end expiration, what I have in blue, alveolar pressure will rise in an exponential fashion because the flow is being delivered most aggressively and most rapidly up front because the pressure difference is the greatest. So in the beginning of inspiration, you will have a very large explosion of flow that we call this exponential rise, what I have in blue towards the bottom. And then what it does, it starts to taper off because as you move through inspiration, that pressure difference gets less and less. So the highest pressure difference is in the beginning of inspiration. So you'll have the most volume rise in the beginning of inspiration. Towards the end of expiration, the volume rise will start to slow because your delta pressure slows down. Similarly, as you move through inspiration, the most flow will be in the beginning. Then as you move towards expiration, if the patient's passive or paralyzed, you will move towards the baseline or back to zero. Then at some point, the P airway will equal the P alveolar pressure and flow will become zero. There will be no more volume delivered because there's no more pressure difference. And then after you move through that 1 second cycle, you will then cycle off into expiration. And then we can talk about expiratory flow curves at some point. So why is this important? This is important because if you are at the bedside and you see this, which is you see this, the patient's on pressure control, you see this waveform, and you notice that, now you won't see the alveolar pressure waveform because that's just something we drew into to highlight that how the alveolar pressure looks as it rises. But what you'll see is these three scales or these three graphs on the volume flow and pressure scalar. But if you're watching the patient and you notice that the flow comes to zero towards the end of inspiration, and the peak airway pressure is, let's say, 20 because it was 5, then you set inspiratory pressure of 15, so the total is 20. If you see the flow come to zero and volume stop, and that's what you notice at the end of inspiration, you already know that the plateau pressure is probably 20. You know that, right? Because the flow is zero. So by the equation of motion, you know that if the flow is zero and the patient is passive or paralyzed, then at the end of inspiration, your P airway should equal your P alv because that flow times resistance component has been taken away because the flow is now zero. So you know that. So in these situations, when some people say pressure control is better because we control the pressure, that's true, but only in this situation. Because if the patient is not passive or paralyzed, then you don't know what the alveolar pressure is. Because if the patient is, let's say, kicking this out like this, and you don't get to a zero, and then you cycle off, at this point where red is, you're not at zero, right? You're not at the baseline. So there is still some flow, meaning that there is still a pressure differential. Now, how much of that is the patient doing? You'd have to sort of figure out. But in that situation, you do not know what the alveolar pressure is unless you measure it. If the patient is passive or paralyzed and they're not contributing to inspiration, like in the examples we have here, we know once the flow goes to zero towards the end of inspiration, which I have in red, that the peak airway pressure equals the alveolar pressure, also known as the plateau pressure, from the equation of motion because the flow times resistance component has been eliminated because flow goes to zero. So P airway equals P alv, and P alv is V over C plus P total. So this was the very beginning of pressure control, what normal looks like. In the following videos, what we'll do is start to manipulate the equation of motion and go through what each difference would look like, meaning if there's increased compliance or excessive or vigorous inspiration by the patient. Because in those situations, you will not know the alveolar pressure. And while it might not be high, you still don't know what it is. So in theory, it could be anything, which gives me pause when I have someone on pressure control. And if I see that you're taking vigorous inspirations in for some reason, I know that I really don't have a handle on the alveolar pressure because there are too many unknowns. Mostly how much work the patient is doing to generate a pressure differential. And the only way to know the alveolar pressure in that situation is to try to get a good plateau pressure hold. So this was the first video. We'll be uploading more in the time to come, and I hope to move through all the other modes of ventilation and their normal waveforms, meaning volume control with decelerating ramp, volume control with a square wave flow, and PRVC. So like the adaptive modes. So this was the first one. Hopefully it was more clear. Any questions, please leave comments or DMs on Instagram or YouTube or wherever you're viewing this, and I'll try to get